So myself and Leila are here to present around becoming a psychological wellbeing practitioner. Just a couple of small things about myself, I suppose. I have around 20 years experience of working in mental health services, both voluntary, community and NHS services. And I spent the last 10 years working in the Improving Access to Psychological Therapy Services, or IAPT, as a PWP and then a senior. And now I have the awesome job of supporting our trainees and apprentice PWPs through their training and becoming qualified. And Leila is with me today, and Leila can tell you a bit about herself.
So yeah, I'm coming to the end of my apprenticeship. So Petrina was my supervisor, which was great and amazing. But yeah, so obviously kind of at the start of just being in that role and then, progressing as such. But yeah, I have a degree in psychology, I suppose. I worked with children with autism before, and then I came to do the apprentice. So that's me. Apprenticeship.
Okay, yeah. So let me change the slides. I forgot I had to press the next button. So before we start and talk about the Improving Access to Psychological Therapy Services and what being a PWP or Psychological Wellbeing Practitioner is all about, just want to talk to you a little bit about the business that we work for, which is Vita Health Group. Vita Health Group has been delivering both physical and mental health services for over 30 years. They work in partnership with the NHS to deliver physical and mental health services across the country. They also work with some of the UK's largest companies in supporting them and supporting their workforce. And they also provide physiotherapy to private clients. So there's a whole array of services and support that Vita Health are delivering there. And it's really an innovative and creative place to work. There's a really friendly environment to work in. And the Improving Access to Psychological Therapy service that Leila and I work within is based in Basildon and Brentwood. Okay, so I want to tell you a bit about the history of IAPT and some things around that. And what we'll cover today is a bit about the history of IAPT, some stuff around the step care model, what psychological wellbeing practitioners do in their day-to-day work. Then Leila's going to do and tell you a bit about the best bits of working as a psychological wellbeing practitioner and her experience as an apprentice and what that felt like and what was involved in that. And then I'll talk to you a little bit about the trainee route, which is slightly different. And then we'll look at some top tips around applying for these roles, because competition is really fierce. But if you were interested, we've got a couple of jobs at the moment for both apprentice and trainee psychological wellbeing practitioners that are on our website today. The closing this evening. But job adverts normally come out around September time for the January cohort, and then perhaps January for sometimes an April start, and then sometimes June for a September start. So it's quite a kind of ongoing process, come out quite frequently. So if this is something that interests you, have a think about it and have a look, really. I heard someone's phone ringing. It wasn't mine, by the way, but yeah. Okay, so having a think about the history around IAPT, it came about around 2008 following a report by Layard. Basically, Layard identified that there were a significant number of people who were receiving incapacity benefits because they had anxiety and depression, and that actually if we could treat this anxiety, depression and support them in getting back on their feet and into recovery, that they would then no longer need the incapacity benefit to be able to work. And by doing that and reducing the amount that was paid out in benefits in this way, the service would pay for itself. So this was the idea. And around the same time, there was two demonstration sites, Doncaster and Newham, and they demonstrated the effectiveness of cognitive behavioural therapy in treating patients with common mental health problems. So cognitive behavioural therapy, another acronym here for you, CBT, we're full of them, IAPT, PWP, CBT. If I say one you don't know what it is, then just ask me and I'll explain it as best as I can for you. Basically, cognitive behavioural therapy looks at physical feelings, thoughts and behaviours and how we kind of get stuck in certain cycles. And cognitive behavioural therapy basically looks at how we can break that cycle. And we use this kind of structure when we're assessing patients to see where their symptom clusters fall, so we can identify the best treatment for their presenting problem. But it also is helpful in us supporting our patients in understanding what's happening for them as well. And it is the model we work around when we deliver our guided self-help. So Psychological Wellbeing Practitioners offer support for patients within the step care model, and it's step 2, and we'll look at the step care model in a second. And basically the whole idea about the step care model is that we deliver and offer the least intrusive or burdensome treatment for that patient with the greatest chance of them recovering. So that's the whole idea around the step care model. We can have a look at that here. So basically services are kind of separated like this. So we've got our watchful waiting at step 1, which is basically your GP identifying whether there's an issue and perhaps seeing if it improves or not, and also referring into services like ours. And then we've got step 2, which is low intensity, which is what myself and Leila do, which is guided self-help. So we support people experiencing depression, mild to moderate panic disorder, again, mild to moderate general anxiety disorder, and also obsessive compulsive disorder, where this is mild to moderate. And we use a whole array of kind of techniques in terms of guided self-help treatments that we're taught within the university course. And then we have our high intensity colleagues who also work with people with depression and panic and GAD, although those symptoms are usually more severe or enduring. And they also offer treatment for people experiencing post-traumatic stress disorder and social phobia. And those two things we don't support at step 2. They always go for step 3. So this is kind of an idea of what the structure is like. And it's worth pointing out that before the Leila report and before IAPT came about, there wasn't across the country kind of support for people experiencing depression, anxiety in primary care. It was very much patchy. Some areas had something, some areas had nothing at all. And also the type of treatment that you were being offered could vary significantly. And the training that that person had who was delivering that treatment could also vary significantly. But through IAPT, we've got people who are trained to deliver high intensity therapy for these conditions, and ourselves who are there to deliver treatment for people experiencing the conditions that I've just described for you. So what are we doing as qualified PWPs? Well, we provide high volume, low intensity cognitive behavioural therapy. And what does that mean in practice is we basically see a lot of patients and we support them in around 6 sessions in terms of their treatment to look at, and work with them with their guided self-interventions to support them into recovery. For some patients, this is enough, and for some patients, they need a little bit more. Or when working in treatment, we find that actually there are some other areas that they need to explore or would benefit from working on, in which case we step them up to be seen by a high intensity therapist. We do the majority of assessments across IAPT, and so patients can self-refer or be referred by the GP in all services now, I believe, across the country. So we do those assessments and we assess for suitability for IAPT, but also consider whether this patient would need additional support with an external service. That might be a specific service, for example, childhood sexual abuse or domestic violence, services that we commonly signpost out to, as well as drug and alcohol services as well, or secondary care services where someone's presentation indicates that they need support for a condition such as psychosis or personality disorder or manic depression, or there's something else there that where the risk needs to be managed in a different way. So we assess people around their risk, around their suicidal thoughts, plans and intentions, put lots of things in place for that, which can again mean that it might have to refer someone to crisis team. We look at safeguarding concerns that might come at that assessment as well, and try to ensure that we provide the best support and care for that patient. That might mean involving other services to ensure that they are safe and the people around them are safe too. So like I said before, we provide step 2 treatment, which is on average around 6 sessions of guided self-help. And we work around the interventions that we've been taught to support that patient with them. And one of the most interesting things for me is really the job is always different. There's always the patient you're working with. They may have a similar theme to other patients you work with, but it's always, their story is always different. And also the way we tailor that intervention to that patient is always slightly different because it needs to meet the needs of the person you're working with. Our clinical hours are split between assessment and treatment, and this can vary in terms of what service you're working for. The IAPT manual says that we should be working towards delivering around 18 to 20 clinical hours for a full-time person. Again, this can vary from one service to another, and depends very much on where the area of need is. If we've got more people waiting for assessment or more people waiting for treatment, we have to kind of target our resources to ensure that we're supporting people the best we can. Every PDOP has case management supervision with a supervisor, so it's not all on you to kind of work out what they're presenting with, what the best treatment is. You'll learn those skills through your university training, but it's kind of good to have that support to kind of look at that patient and think about, are we doing the right thing? What else could we do? Are there any other adaptations we could make? We also look at recovery rates and how that patient is progressing. People complete questionnaires to kind of see where they're at in terms of their level of depression, level of anxiety, and what we're hoping for is to see that improve. But if it doesn't, what other support can we offer? And all psychological wellbeing practitioners have access to clinical skills where we're always kind of developing and our knowledge and understanding and keeping up to date with the most kind of recent ideas and thoughts and evidence base that there are around treating specific kind of conditions. So that essentially is what it's like to be a psychological wellbeing practitioner. It is a very busy role, but it is very active. You're always involved in doing something. You're never going to be bored, put it that way. Okay, so Leila's going to talk about being a PDOP and the best bit.
So there's a lot of best bits about being a PWP. So firstly, as Petrina said, every day, every patient is different and brings a new set of challenges. So if you like, people in a sense, or if you're just interested in psychology, or, it's just very, like Petrina said, it's lots of different aspects to it. Everyone's kind of got their own issues that they bring to the assessments. Every treatment session is different, so it's very fun and different in that sense. Definitely always learning and growing as a practitioner. Always opportunities to kind of understand a different problem descriptor. I'm learning, how to kind of explore different symptoms within assessments, asking colleagues or peers and my supervisor and managers. Really fun to kind of constantly grow and learn. Lots of areas to do that. So with the low intensity CBT interventions, we can guide the patient in gaining insight into their low mood or anxiety and support their recovery. Even in assessments at the end, patients often say it's been really insightful for them to understand what's happening for them, what are they thinking, what are they doing. So it's amazing to kind of be on that journey with them. It's very rewarding in that sense as well, which I'll talk more about in my own experience a bit later as well. And obviously being a part of their recovery, that's a really great experience to be able to see their scores move towards recovery. Maybe they came very worried, feeling very low, and then hopefully towards the end, they're in a very different place. So opportunities to vary the mode of therapy of step 2 treatment. So of course you have face-to-face therapy. You can work with them over the telephone, working with SilverCloud, which is an online database of CBT modules. And then you could do group therapy, working on kind of webinars, of course, or on videos. And then so as experience and confidence grows, there's a potential to access supervisors training. So definitely kind of exciting to think of how you can kind of develop your learning, grow in your role. Obviously, as it says, kind of doing the supervisor training, you can become a manager or do the high intensity training after some experience. So lots of opportunity there. And of course, as I mentioned, being a part of the patient's recovery. Petrina, do you want to mention about the champions?
Yeah, so there's always kind of scope for people to get involved in doing different things. So if they've got a particular interest in a specific area, maybe that's long-term conditions or perinatal, they can kind of own that area really and develop resources or webinars or kind of make better links with different people in the community in terms of other services, so we can develop those pathways and develop an area of work that might not have been otherwise there to kind of support a need that's kind of demonstrated through the data that the service holds as well. So lots of different areas kind of develop and grow as a practitioner, but also using those own interests and skills to develop something different perhaps as well. Are you all right, Leila?
Yeah.
Oh, I need to change the slide, don't I? Sorry, it's my fault.
And then you're going to talk about the apprentice route.
Yeah. So the apprentice route, you need to be 18 plus. You just need a GCSE English and Maths A to C equivalent. You need to be able to demonstrate that you can you need to be able to demonstrate that you can undertake level 5 work. So what normally happens is, if we've got someone who hasn't got a degree as a background, which is absolutely fine, we want people who don't have a degree, to be honest with you, because we're looking at bringing different types of people into the role. So if you haven't got a first degree, what the university will do is they'll set you an essay or something for you to write a piece of work on when you come for the interview, to see how you get on, to see whether you'll be able to manage working at a level 6 level of work, in terms of being able to complete the course at an undergraduate level. We're looking for people to have experience of working with mental health. That can be a variety of things. That could be in an administrative role. That could be in a caring capacity within someone that you know. It doesn't have to be an official role. It can be a variety of volunteering, really. So looking for you to have some experience, but like I said, you don't need to have a degree. Just being able to demonstrate you can work at that level. You'll attend university 1 day a week. You'll have a study day and 3 days in service. It is paid at band 4, and the course is all paid for as well. At the end, you'll complete an endpoint assessment, which I think Leila will be able to tell you a bit more in detail about. But it is a fantastic opportunity. It really opens up the doors for perhaps people who've got interest in mental health but haven't perhaps got that psychology degree. So it takes away that barrier for people. So we want to get people from lots of different backgrounds, lots of different experience, who can come and bring all of these skills to the role, really.
So I'll talk about my own personal experience of being an apprentice, and I'll kind of explain the more practical sides of how we learn and what we learn, and I'll also kind of touch more about, like I said, how much I enjoyed it, basically. So firstly, in Module 1, we learn about assessments and how to do assessments, and then in Module 2, we learn about treatments and, of course, how to do them. And then in Module 3, we learn about diversity within patients and how to adapt our care to help them. So in terms of how we're assessed, firstly, it's quite fun because you're doing role plays with peers. So one person kind of pretends to be a patient while the other kind of practices their clinical skills. And then you kind of send in recordings to your supervisor, and then you kind of get yourself signed off, and then you're working with patients, which is really fun. And then you have an exam, which is in that same way, kind of one of the assessors is an actor, and they pretend to be a patient, and you kind of show your skills in that sense. And then in Module 2, it's a similar way that you're assessed, but you just kind of send in a recording of a treatment session with a patient. And then in Module 3, there's a presentation. There's also a reflective essay in each module, and there's also a portfolio which needs to be completed throughout the course. So there's kind of logs within that, essays within that as well. So it's quite fast-paced, quite a lot of work to do. So definitely recommend kind of being intentional with finding the boundaries of kind of work and study, and also, seeing friends and family and enjoying things as well. You definitely kind of have to find the balance, and like I said, be intentional with that. But it's very fun. Very fast paced. So kind of be prepared to, be on top of things, I suppose, and kind of work where you need to. It's a very rewarding experience. So like I mentioned, especially at university, it's amazing to kind of come to the first lecture not knowing what an assessment is or how to do it. And then before you know it, you're kind of ready to work with patients. And it's, especially in a year, you kind of find yourself learning a whole new career role, which is very rewarding, very great sense of achievement. And there's kind of lots of people who you can kind of ask for support with that, peers, colleagues, like I said, supervisors, managers, so much support there just to kind of help you get to that place as well. And obviously in-service work is very rewarding as well, as we kind of touched on quite a lot. As a apprentice or trainee, you get to a point where you've done 6 sessions with a patient, with multiple patients, and you've kind of gone through that recovery journey with them and kind of supported them to that place, seen their scores kind of move every week, hopefully towards that place. And I've got multiple kind of experiences in my mind that I remember, but one specifically was when one person was kind of almost skeptical about CBT and wondering how it can help them. And then obviously we talked about some psychoeducation and went through the treatment, and it was great to be a part of seeing the insight that they gained and obviously seeing their scores move towards recovery. And because there's kind of a high turnover of cases, you have 6 sessions with a patient and you're seeing multiple patients, you kind of get that experience quite a lot. So it's very fun, very rewarding, great sense of achievement, very kind of supported throughout that progress. Like I said, lots of people around you can ask questions. One thing I recommend is kind of speaking to colleagues and peers, because from my experience, when I shared kind of a question that I had or something I was struggling with, lots of other people felt the same too. So a great sense of kind of learning community in that sense as well, especially since you're kind of working and you're studying with your peers. So it's different in that to other courses in that sense, which I like. And then, just lastly, just to touch on, apprentices have an endpoint assessment, which is like an extra day of exams, which is just kind of one of the differences between the apprentices and the trainees. But yeah.
Cute. So it's really nice to hear what the apprentice route is involved in. Like Leila said, one of the differences between the trainee route and the apprentice route is the apprentices have the joy of doing another full day of exams where they have to do the assessment, the treatment, and a presentation. So it is full on, and the course is very fast paced, as Leila kind of described that. But it's really nice to hear some of the positives that Leila's had from her experiences of especially watching patients and being part of that recovery journey. It's really fantastic. And the trainee route is similar. Rather than doing the undergraduate, you tend to do the postgraduate unless you don't have a first degree, in which case the undergraduate is an option. It's split into 3 modules: assessment, treatment, and values, diversity, and context, which is also what Leila will have done. You do 2 days at university, 3 days in service. One of those days of the 2 days is usually a study day, again paid at band 4. And the support you receive in service, we tailor that to complement what you're learning at university and support you in kind of starting that clinical work at a pace that you feel able to, but also one that complements your competencies as well. So posts are usually advertised, like I said, May, June for September start, December for a March cohort, and competition is really fierce. So really think about when you write those applications, what you put in them. I've been shortlisting today, and for sometimes people just don't write enough. Look at that person's spec and think about what's been asked of you and demonstrate how you meet the different areas of that person's spec. Because if we've got 100 applications, we're having to score all of these. And if we're scoring them and you haven't written about a certain area of that person's specification, I won't be able to give you any points. And there you don't get an interview, even though actually you might be really, really awesome. What also really helps is gaining some experience, either paid or voluntary, to help back up that application. And it also gives you an opportunity to see whether you actually like this type of work, because it is difficult when you're listening to people's experiences and what they've been through day in, day out, and you're supporting patients. It's rewarding, but it also can be very difficult. So have a think about whether this is something that you actually feel that you want to do. And by doing some voluntary work, you might get an idea of I actually really enjoy this, or actually maybe I'd like to work with people but in a slightly different way. Read the literature and prepare for your interview. I've got some references at the end of this presentation, but there's some really useful things to have a look at. The Reach Out Guide is very useful for psychological wellbeing practitioners. It talks to you about the whole assessment and treatment and what's involved in all of those things. It just shows you have a knowledge. Having a bit of a Google around IAPS and using some information we've taught you as well will help. The interview usually involves a role play, but we're not looking for you to do a full assessment. It's a 10-minute thing. And what we're looking for really is looking at those common factor skills, you showing some empathy, some good listening skills, but also having a think about what kind of questions you might ask a patient if you were first meeting them and assessing them. So have a think about those things. And also, like I was just mentioning, really consider whether this is something you want to do and how that will kind of impact on your well-being, and thinking about if this is the right time for that. In terms of progression, you can move on to being a senior psychological wellbeing practitioner, a step 2 lead, a lecturer at university for the PWP course. Some people want to move into high intensity after a couple of years. That's something that you can do. And it's also been a popular route for people who intend to train as a clinical psychologist. The rules around accessing NHS training funded by HEE means now that you have to be in the role qualified for 2 years before you can access another set of training. So you would have to stay within this role for 2 years before you could go on to something else. But it's a fantastic job to do. And for lots of people, this is the career that they want, and they remain as psychological wellbeing practitioners and they enjoy the variety of the job. For other people, they want to try out other things. But it's a great opportunity to work within the mental health field and be a part of that patient's journey and make a difference. Yeah. So in terms of useful resources, there are some there for you. Happy to copy them up and put them in the chat if that would be helpful. But yeah, so I'm hoping that myself and Leila have given you a good overview of what it's like to be a psychological wellbeing practitioner. I think it was really lovely hearing Leila's experience firsthand. She did a far better job than I can convey of it. So it was really, really awesome to hear that.
Apologies for the slight delay there. Petrina, thank you so much for giving me your time today and for sharing your insights. I think it was particularly interesting for me. The last job that I worked before for my current one was a GP rotation. I had a lot of interaction with IAPT, but it was really interesting to hear that extra bit of context because it was one of the things that really struck me about the job was the availability of this incredible psychological support service that was in stark contrast to the services that I've experienced elsewhere, and seeing the range of services that are on offer, and also the volume of patients that you're able to accommodate is, I think, an immense achievement. And Leila, thank you so much. It's been fascinating to hear your first-hand account of the apprenticeship as well. I think with all those specifics that you've shared, all of our attendees will certainly be very well prepared should they want to pursue the same route as you. So we do have a question in the chat from Arathi, hopefully my pronunciation is correct, who asks, if I have BPS accredited psychology conversion course, can I apply? I think that's to the apprenticeship program.
Either. Apply for either, absolutely. Yeah, because we've got that interest, but also not just about that qualification, it's also about what you kind of show in terms of the experience you've had with people. Yeah, absolutely, 100%.
Brilliant, thank you. Hopefully that answers your question there. I do have a couple of questions for both of you, actually, if that's okay. So I think it was kind of alluded to in one of your slides there, thinking about the impact on your own well-being. Obviously, with the nature of the work, I can imagine that there are often, working with people with the generalized anxieties or panic disorder and depression that you do, there are often some fairly, traumatic life events that you encounter. And I was just wondering how do you, the question for both of you, how do you go about kind of looking after your own well-being while helping to improve that of others?
Do you want to go first, Leila?
Yeah, I think there's lots of things. I think one thing I've definitely learned, as I mentioned, is that balance, boundarying work, and then boundarying, when you finish work, making sure that kind of seeing family and friends and things like that. That's quite important to kind of recognize my role and the limitations of my role. At uni, we talk a lot about more towards kind of sympathy in time rather than empathy. So rather than kind of being in the same place as a patient, it's kind of putting a ladder down and helping them and supporting them in that sense, rather than kind of jumping in the boat in that sense. So again, kind of recognizing limitations of my own role. And also, things like clinical skills. If you're ever struggling, it's also a place where we can come and air and share with other peers and colleagues. And it's definitely kind of definitely doable, definitely fun. But it's, I suppose, some people more than others, maybe just being more intentional with that balance.
Yeah, and I would agree. I think, making sure that you maintain all the things that give you pleasure and enjoyment, and you kind of watch out for a sign that some of these are dropping off or I've stopped doing them, and actually maybe I'm not feeling so great myself, and thinking about that. But also having awareness of what pushes your buttons. We all have our own buttons, and if we encounter a patient who's had a similar experience, that might, push our button for ourselves, and thinking about how we feel about that. But also there's lots of opportunity within our team to kind of talk about it in case management if you've had a really difficult patient. And it might not be that it pushes your buttons, but just hearing what they've experienced has it was really hard to hear what they've been through. They've been through an awful experience. So kind of having that opportunity to kind of discuss that and describe that and talk through that can be really kind of helpful. But yeah, it is about balance, absolutely.
Well, I'm glad to hear that there are measures in place to kind of take care of your well-being as well. It's an incredibly important job that you do, and obviously your well-being is paramount as well. I had kind of a two-part question as well for the sort of both of you. It is relating to COVID, so I apologize. I think there's a lot of people sick of hearing about COVID, but I have some quick questions relating to it. Firstly, for yourself, Petrina, I know certainly during the pandemic there was a lot of concern about almost a second epidemic and a fallout relating to lots of people requiring additional psychological wellbeing support. Is that something that you've seen, an increase in demand, an increase in your caseload? after the resolution of the pandemic, with people struggling from issues that have developed during it? I know you guys are always incredibly busy, but
for me, there was some PTSD coming through for people who'd been in ICU and had those experiences, or had some really difficult experiences, or a relative had been in ICU and not being able to see them. There was some distress around that as well. In terms of anxiety and depression relating to COVID, not so much actually anymore. Sometimes we get patients who are still quite fearful of contamination and germs, and that seems to have been triggered by all the kind of regulations that were put in place, all the face masks, all the kind of advertising, all that kind of thing, all the kind of restrictions were all placed under, right? And that hasn't really left them. They don't feel comfortable taking their masks off and those kind of things, and they really feel very apprehensive. But actually, I think the biggest risk to people's mental health now is the cost of living crisis. I think that will have far wider implications the longer this continues for people's mental health. We have patients working 60-hour week and not being able to afford to live. This is going to be the real problem, I think. Whereas for most people, it was quite difficult, it was upsetting. They weren't able to do their pleasurable activities and see the people they loved, and lots of balance left their life. But it's come back, and actually that seems to kind of remedied that for most people. You still have some people still finding that difficult. Older people, actually, a group of people that we're seeing are finding more difficulty because they haven't been able to go back, or their friendship groups have changed, or people are no longer coming to see them, where the routines of people have changed and now they're finding themselves more isolated. But yeah, I think overall the cost of living crisis is really more likely to create far more difficulty for people's mental health.
Yeah, I think it's only going to be a challenging, probably few years at least, I'd imagine. But I think it's very fortunate there are services available that are able to help people through things like this. For yourself, Leila, I was just wondering whether or not, also linked to the pandemic, whether you'd had any kind of disruption to your process of going through the apprenticeship as a result of the pandemic, and how you dealt with that, if that is the case.
The only thing I would say is when I came into the role, we were already working on the phone, and I think beforehand it was different. It was more face-to-face. In our service, we haven't got as much face-to-face, I know, as we used to at the moment. Not sure what the plans are for the future. In terms of uni, uni was online, and then I think there was time where we kind of wondering, are we going to go in person or not? Because I think the whole country was kind of wondering that. But towards the end of the course, I think it's protocol to actually have experience face to face. So they definitely made the most of having us in person, so we could do role plays with each other face to face, see each other at uni. So mainly uni was on course, uni was on calls, Zoom calls, things like that. Yeah.
Well, it's a fantastic achievement to have gotten through it under those particularly trying circumstances. I'm sure it's not an easy thing to achieve at the best of times. So very well done for that. I think it looks like we've gone through the question in the chat. So I think unless there's anything else or any closing remarks that either of you wanted to make, we could perhaps bring the session to a close. I just wanted to offer my thanks and gratitude again to both of you for joining us today, and also on behalf of all of our attendees for the wealth of knowledge and experience that you shared with us today. So thank you very much for joining us.
Thank you for inviting us. We were really pleased to come. Thank you.
Yeah, thank you.